Hello, Andy. It is Dr. Ravi Kumar Mamilla, Senior Consultant Neurosurgeon, Brain and Spine Surgeon, Hyderabad. Today, I am going to tell about what is SBO, Skull Base Osteomyelitis. It is fatal infection of skull base, especially lateral skull base and central skull base. It usually occurs in the immunocompromised individuals, especially individuals over the age group of 65 years, diabetes patients, transplant patient, and post-chemotherapy radiotherapy patients. And the source of infection is especially these infections spreads from the external artery canal, that is called malignant otitis externa, and sinonasal. From the sinonasal infection also it spread to skull base, especially frontal sinus, sphenoid sinus, ethmoid sinus, and maxillary sinus. Dental infections, oral infection, any surgical procedures being done in the oral cavity, dental, and in the tooth or in the pterygoparietal region, they may spread to skull base. There are two types of skull base infections, especially lateral skull base and central skull base. Lateral skull base usually involves the petrous part of temporal bone, tympanic part of temporal bone, mastoid process, and styloid process, and temporomandibular joint, and zygomatic region. And the central skull usually caused by the Pseudomonas aeruginosa, Staphylococcus aureus, Proteus klebsiella infection, sometimes fungal infections like Candida, most commonly Aspergillus, Mucor rhizopus, Mucor, and sometimes Candida infections. Central skull base infection occurs in the clivus region and the central part of occipital bone, even the sphenoid, central part of sphenoid bone. It spreads from the sphenoid sinus, ethmoid sinus infections. Then what is the clinical presentation of SBOs? Skull base osteomyelitis. Because of involvement of skull base, they will have severe ear pain, that is a very severe agonizing pain. It is usually more severe during the night time because of increased intraosseous pressure. This pain, ear pain, that doesn't subside with the routine analgesics medications, routine painkillers. Ear pains usually occurs in the ear and in front of ear, behind the ear, above the ear. Sometimes this pain may spread to whole half of the head. This is called routine head, a generalized head, spread like a generalized headache. Next is ear discharge, usually in the ears. It may discharge may be scanty serous discharge. Later it may be converted into blood-stained purulent discharge. If the infection further progresses, they may present with different cranial palsies like facial palsies in the form of deviation of mouth and lower cranial palsies because of involvement of jugular foramina and even with the involvement of petrous apex involving the sixth and fifth nerves. Because of cranial palsies, like they will present with the mouth deviation, they may have difficulty in swallowing. While swallowing, they may have choking sensation, difficulty in breathing also sometimes because of lower cranial nerve involvement. These are if the further progression, there will be pain in the temporomandibular region. So coming to diagnosis, these clinical profile of the patient, especially elderly patients with diabetes, with history of dialysis patients, immunocompromised individuals. Diagnosis wise, HRCT temporal bone, plain and contrast. In a plain imaging, we can see erosions of petrous bone of bony part. In the contrast images, we can see soft tissue enhancement. Then MRI, plain and contrast. In this, the bone marrow, the petrous bone. In the bone marrow, there will be loss of fatty streaks. That's why in the MRI, in the T1 weighted images, there will be hypointense. In T2 weighted images, there will be hyperintense because of a loss of fatty streaks. And on contrast, there will be enhancement. Then coming to radionuclide scanning, technecian and gallium scanning. Then coming to treatment, those patients with mild infection, usually they will respond with IV antibiotics like ciprofloxacin, piperacillin, tazobactam, cefepime, ceftazidime. Those patients who do not respond with medications, usually surgery will be done. Main aim of surgery, surgical decompression of skull base osteomyelitis, and if the patient involves lower cavern nerves and facial nerves, there is other indication for surgery. These are red flag signs. If the pain is not subsiding with IV antibiotics, we should go for surgery, especially intratemporal fossa type A approach will be done. Thank you.